Well, welcome again. Good morning. This is the first of a five-part series. You're welcome to join any one of them or all of them. We will send out additional notices. The series is entitled The Five Pillars of Financial Effectiveness for Rural Hospitals. Today, we're going to be talking about physician contracting and compensation. I see many names on here. I'm familiar with a lot of you, so good to see you again. For those of you who don't know who I am, my name is Steve Febus. I am the Director of Advisory Solutions with DZA. I've been in this role, about a half a year. Prior to this, I have spent 38 years, mainly as a CFO for a PPS hospital turned to a critical access hospitals at the turn of the century. And yeah, I probably shouldn't have said that. I am old, but been around for a while, done a lot. In the early 90s, worked to merge two hospitals together. They were relatively in close proximity, created a sub company for collaborated services, billing, purchasing, procurement, fiscal. Went at that for about 3 years. It became really evident that the communities were really wanting to have their own local facilities, and so that uh, fell apart. So as that happened, I became the CFO of one of the local hospitals there and stayed in that role here until October. So I consider myself a recovering CFO at this time. But today we're going to talk about physician contracting and compensation. We're going to um, have an opportunity to share some ideas, some thoughts. You will be in listen only mode, so please feel free to put any questions you have within the chat. So let's get going. We have only an hour. Of course, we got to start with a disclaimer. This is intended to be educational only. It is not implied or expressed to provide you with any legal representation. If you would like additional support in your analysis and stuff, definitely we're available. There are services out there. I will provide you with some solutions you might want to think about as you embark in your journey towards really this transparent nature in your physician compensation, your recruitment, and your retention efforts. All right, enough of that. Let's get going. So, an overview. What are we going to talk about this morning? Well, number one, I think we need to talk a little bit about rural provider landscape. You might feel like, well, let's just jump right in the middle of this. But if we don't know where we're at, we're really going to have a tough time to know where we're going to go to. So during the course of my career, I have seen significant challenges in the healthcare environment. All of these play a pivotal role into your recruitment and retention efforts. And so they become part of that fabric as you're thinking about development of your strategy. In the early days, many of you may not have been around in that. Most of our rural hospital medicine was provided by RNs and often staffed by local providers who shared call and responsibility burdens as just part of their normal practice. They weren't employed. However, in the early 90s, there was a tremendous effort of hospitals acquiring physician practices, primarily in urban settings, to really drive market share. Rural settings were a little less advanced, but today I would bet many of you have some type of employment model, definitely some alignment with your providers within your communities in order to successfully recruit to your communities. So by the time I ended my career with the facility I was working for, we had 17 clinics and a plethora of different arrangements, many of which we're going to talk about today. Need to design your efforts within the transparency of your process and your development. Remain in compliance, huge importance. Make sure that you're within the fair market value and that you want to build trust, long-term trust with your providers. So that's what we're going to talk about. So where are we as a rural healthcare landscape overview? Well, number one, we know what a rural area is. What are we recruiting to? Typically small communities. Most all of us are in those communities today. generally less than 50,000, providing rural health to that community. Within that rural healthcare environment, rural communities oftentimes to have a higher rate of people without insurance, or face many barriers in terms of timely care. This is no more true today than it was 10 years ago, but we're seeing a preponderance of challenges in terms of just access to not only care, but access to insurance to be able to provide that. So many people go undiagnosed, typically seek care late in a environment in which it becomes more critical for longer term success for their health. And so that's a challenge rural hospitals often face. This is going to be even more challenged as we face the future, especially within the Medicaid arena. So where are we as an industry? Well, first and foremost, we have a shrinking provider supply. We will share a little bit later in the following slide, this whole provider retirement cliff. And then we have raising patient demand, not only due to the pervasive amount of illness, but also an aging population. The regulatory and reimbursement challenges continue to be what they are. In fact, I was listening to a webcast this last week. One of the largest national private companies was testifying in front of Congress and really put the face of healthcare challenges in terms of cost at the feet of hospitals. I would tend to push back a little on that. I don't think that we control the market. We're usually the back end and providing the care. There is so much other dynamics within the healthcare spend, but we equally contribute to it. And so it's very important that as we think about alignment and definitely sustainability, how do we model that? But in that regulatory environment, we have the latest, the One Big Beautiful Bill, or HR 1, in which Medicare is slated to lose in the neighborhood of $1 billion in reimbursement over the next decade. What does that mean for hospitals, especially in rural America, in which you have a heavy reliance on the Medicare, Medicaid program itself? The reality of it is we will continue to be faced with this, and that'll be our challenge. Also, new technology is in place. Now, when we're thinking of the physician component to that, this is both good and bad. Your EMRs, I've heard it said, which EMR do you hate the most? And usually it's the one you're on today. And it's just the fact of life. We are, the computer technology continues to increase. Sometimes it doesn't necessarily improve our life. It makes it more complex. But it's there, and we need to take that into account when we are developing our contractual models. There is advancements in AI. I will briefly talk on that as we progress. But you think about where we were, 5 years ago in 2022, AI couldn't do simple arithmetic in a reliable nature. It would confidently tell you 7 times 8 is 54. And hopefully most of us know that is not true. By 2023, it could pass the bar exam. 2024, it could write working software and explain graduate level science. There are so much advancements today that are tremendously moving that pendulum forward. In the next 2 to 5 years, we're going to see major disorientation in terms of what can be done. But what are you doing today that is aligning that technology with your contracts? Think about how you might leverage that. Some tools out there, AVO or DAX. I have one clinic that we worked with, early adopter in the DAX, which is an ambient solution for charting. It changed the provider's life. He was spending 3 to 4 hours at the end of a day documenting. When we implemented and rolled this out, by the first month, he was spending 15 minutes to 20 minutes and then going home at the end of his shift. It changed his life tremendously. It probably bought us another 4 years with him as a major provider in our community. He was getting to that level of burnout. Today, we rolled that out across all our clinics in order to improve their life. And then, so we had to build that into the comp models. We're going to talk about compensation models today in rural healthcare. It's really trending to de-emphasize productivity and moving a lot to a minimized risk-based measure. I will share a little bit more of what that means as we progress. So where are we with physician supply and demand? If you're thinking of retention and recruitment, what does that mean for you? Here in 2020, AMN, formerly Merritt Hawkins, put out a supply and demand factors with the 7Ps, population growth being huge growth in the next few decades. Our aging population by 2034, we will have more seniors 65 and older than we have children 17 and younger. This is the first time in history that this has ever occurred. So that with that comes more, you know, resources required. Older people visit the physicians 3 times the rate of younger people. And so the supply is limited. You've got even our physician population aging, 45% of those physicians in active practices today are 55 and older, and they're tired and they're looking for getting out of the service. But we've capped how many physicians we cap. Now, there is a lot of talk about improving that over time at the federal level and releasing that cap. But as we know, it just takes time. And so how do you actually get that throughput and then actually recruit to your area? And that's much going to be around how competitive you are within that environment of compensation. Provider burnout, we have pervasive ill health. 60% of adults have some type of chronic condition. Of that 60%, 40% have 2 or more underlying comorbidity conditions. And so, challenged when they come to see the physicians, they often need more care and more oversight, which then takes away that opportunity to see additional patients. Yet, we have more and more that need care. The pipeline problem and then practice styles. So how do we improve those practice styles in order to then successfully recruit to an environment in which a physician wants to practice in? In the rural provider landscape, you have this retirement cliff occurring, meaning that we have that 45% that are 55 and older coming to the end of their career. Oftentimes, if they're staying involved, they want to look towards an administrative function than that day-to-day clinical aspect or some hybrid. So that might be an opportunity in which you can leverage in order to keep providers a little longer, but how do you do that and continue to be sustainable? You have aging rural populations. You have access going to be a challenge with the Medicare changes within HR1, which really, again, those were primarily targeted for this fraud and abuse side of it, but it's going to hit a tremendous amount of Americans that won't have access anymore. Or in order to get access, there's a lot of hurdles to continue to apply. So be thinking about how do you set up your organization to help support that. Geographic isolation limits your recruitment abilities. Sometimes call, which is a component of your compensation, can be a huge hurdle for providers that are thinking about coming to a rural setting versus an urban setting. Reimbursement trends. So typical rural hospital patient volumes don't support that of an urban. That's like yeah, right? No, no kidding. But what are the challenges you have that? Well, you're competing against urban settings for that market. You have a limited supply, so you have to pay equally, but you don't have the patient volume to help offset from a reimbursement standpoint. So how do you develop a compensation model that is fair and accurate and within reason? A recent study by the Turquoise Health Group determined through all of their analysis that rural hospitals, on average, across the United States, are paid 33% less than the urban facilities. When you think about that, and you know your Medicare, Medicaid is capped out, you're only going to get your cost plus 1%, minus 2% for sequestration, and again, it's only allowable cost. At some point, the only place you make money is through commercial and self-pay to some extent. In rural settings, that's usually more of a challenge, but It's those commercial contracts. And that's the reason for the second in our series is on contracting, but we won't talk about that right now. But what that means is we're challenged because we just don't have the volume nor the expertise to be able to often negotiate contracts that actually provide us the ability to be sustainable. So therefore, we're often paid less, yet our costs sometimes are higher. And we'll share that within this whole physician compensation component in what you're recruiting to. But many rural hospitals are too small. You're financially tenuous to begin with. I heard it said, there's over 400 rural hospitals right now that are either thinking of downsizing or closing their doors, just because it's a challenge and we often run on really thin margins. Financial realities of critical access hospitals today. Number one, low patient volumes compared to your urban facilities. So when you're developing your physician compensation, those expectations, you have to know your own market. You can't have hope so's within that, hope that, you have enough people to come to support that provider when you haven't really done an analysis to determine is that actually true or not. Again, that cost-based reimbursement, you're only going to get 100% of Medicare costs that are allowable costs, which is oftentimes less than your total cost. In addition to that, you still have sequestration in place, so you're actually losing money on Medicare. Your Medicaid programs often pay you less than Medicare because of the time delay. And then you have an increase of the Medicare Advantage plans, which are something you want to pay attention to, whole different subject, but you're going to have to really pay attention to those negotiations because oftentimes those Medicare Advantage plans want to come in and pay you less than Medicare. To make it a lot of sense, you're losing money already. Let's not lose more money. But 44% of rural hospitals had negative margins. So why does that matter for what we're talking about today? Well, provider alignment drives quality and access. Your compensation models need to really protect you against federal regulations and scrutinies. You need to be transparent in order to build trust across that continuum, from your providers to the organization. The right model will attract and retain talent. And so it's really critical that you think about that alignment. When was the last time you looked at your agreements? Have you aligned them? Have you evaluated them for potential gaps? I would highly encourage you to create a matrix that creates visibility into your agreements for your team, whether that be the providers themselves, your administrative team, or even your HR. Do they know what they're administrating their payrolls to? And so that everybody's on the same playing field. What does this mean for provider engagement? Providers are the key to healthcare. We all know that. They drive access. Creating an engaged and active provider base is critical for your long-term success. However, you can't create a model that just actually puts you in financial jeopardy. So you have to balance that, evaluating that right blend. The main thing within that I would encourage you is transparency, talking with your providers about the financial realities of where the organization is at, also providing them with the security. If you're out recruiting and you have days cash on hand of 3, that might be a tough environment, but what is your strategic plan and where are you heading into the future so that in that recruitment process, you're really sharing, although very vulnerable, where you're heading and how they can help support that. All right. So now I'm going to get a little bit more into the weeds of this all. That really tried to frame up the background of where we are as an institution. And then as you actually go to develop your compensational and your alignment efforts, how should you functionally think about that? What I'd like to talk about in terms of the affiliation opportunities as we progress is really what are they? What are the different methodologies and how might you think about using them? One size does not fit all here. The reason I'm talking about this is in the rural environment, you want to be very flexible. You will lose some providers if you only have, this way. We only do employment models, and you can't, they want to come to a private practice or an independent practice or have some form of independence, and you can't offer that. Maybe they aren't a good fit, but have you thought about those alignment opportunities? So let's talk about that real quick. What are some various models in terms of alignment? When you think about that, you have really low level alignment to really high level integration to scope of services and what that means from the spectrum. So on the very low bottom end of it, you will have agreements like medical directorships. You will have recruitment support, all the way to the very high alignment and high scope of practice within the hospital environment, which are oftentimes your employment models or that group project practice employment subsidiary model. Under a recruitment support, I'm not going to go into much detail, but what I mean by that, these typically are independent practice within your community in which you're recruiting to, and you might subsidize that for a period of time, typically 1 to 2 years. Most likely, what I've seen in the past decade have been 2 year support agreements. The reason for that is you want that physician to be able to know that they're going to generate enough income to support themselves through the development of their practice to when they actually have a full panel of patients and actually can generate enough money in order to successfully sustain their lifestyle. So you can do that. There are really there's some limitations, but you want to again have it very clear. You want to have it be precise in terms of length of time and what you're actually recruiting for, so that you don't end up in any store grant at kickback scenario. I'm going to go into the rest of them in a little bit more detail and why you might think about doing that in terms of alignment. But let's start with your key questions to ask in developing your alignment strategy. This is deliberate. I deliberately said this. Do you have a strategy? Are you out just hiring because you have needs? Still should have a strategy, and definitely an alignment strategy. Um, If you don't, get together with your team and build one. When have you really looked at the affiliation models that make the most sense for your organization? How flexible do you need to be? When you go about aligning the economics, what does that look like? And does that alignment create opportunities to grow your practices and increase your market share? Have you looked at what leakage you might have going outside your market and understand the why of that? So these are all strategies in which you're thinking about as you're developing that whole framework. Does your organization generally have trust and transparency in place? If not, how do you develop at that? How is that relationship with your current providers? How has it been with your past providers? So look at the primary drivers of what affiliated models make the most sense for you in your organization. Again, one size does not fit all here. You want to just make sure that you are aligning it effectively to create the strategy and the environment that you want to actually build to in order to be sustainable long term. Within that, you have to think about the regulatory compliance framework. So Stark is your non-referral based compensation. So you don't want to have it contingent on referrals. You will find yourself in violation of federal law. Anti-kickback is really that arm length transaction. Really, I would say it this way. You can't require physicians to refer within. You can actually build that into their contract as a recommendation, but you never want to take away the clinical decision from a provider. If they don't feel like it's appropriate because limitations within the organization and they need some specialty referral out, no problem with that. Never take away their clinical judgment. But you can encourage the very fact that they should utilize your imaging services or your lab services, and make sure that's clear. That's an expectation. It's not a requirement for employment because of the anti-kickback, but definitely an expectation. What this does is this really provides them a seat at the table to have conversations. And that's real important. I'll get into a specific example of that as we progress here. Commercial reasonableness standards. You need to look at that. You need to understand the fair market value requirements. And are you paying according to fair market value? If you're paying well above that, you likely are in violation either the anti-kickback or Stark or both. And so what is commercial reasonableness? Basically, it's more fair market value is about how much you pay, where commercial reasonableness is really determined about does it make sense to even pay it at all? Should we even have that services here? Um, and so you've got to really balance both in that understanding. I'm going to primarily focus on the fair market value because you should, in your financial analysis, make sure it's supportable. And if it's not, then you probably aren't, probably shouldn't actually provide the service, period. But what is fair market value? Again, value is an arm's length transaction consistent with the general market. It's based on national components. It's adjusted for specialties, your geographical realities, and it needs to be independent from volume and revenue. It can't be tied to that, or you'll run into anti-kickback statutes problems. So be thinking when you're developing those, and are you reviewing that? And what does that mean? What does fair market mean? Can you pay somebody if they're working in the 25th percentile of volume, the 50th percentile of wage? Well, the answer to that, again, this is not legal in nature in terms of should you or should you not, but it's possible you can. And why would that be? Well, number one, are you able to recruit? And if you can't recruit to your primary service area, then you may have to pay higher than normal wages, but you better document that. And you definitely want to document why, and then you want to definitely have legal counsel in terms of assuring that your documentation is sound. Some sources, and this is where I would encourage you to utilize an external group to be able to get this information. You can get subscriptions to MGMA, AMGMA data, Sullivan Cotter. These are some national groups out there. There are role-specific data out there that's available to you through the NRHA or Stroudwater. So these are types of services that are out there. What is your model going to represent? I would encourage you not to bounce around all over the place. Don't let every specialty group bring their own. And it definitely define exactly what makes sense to you. I know some use MGMA exclusively. They will use whatever region they're in, and they'll identify that that's our model. Others I've worked with will use a blended rate and may take those top three and say we're going to use the blended of the three to establish our compensation as we look at that. Just make sure you are clear so that there's no expectation behind it, and you're having those discussions later as, well, I really want to use MGMA, but we use AMG. You don't want to be in that environment. So identify it up front, and then also, how often are you going to look at this? Annually? You're going to look at it the term of the contract. Make sure all of those are identified within the structure of your agreement. Okay, before I get into really each of those independently in terms of that affiliation type, something to consider, especially for you critical access hospitals, think about that contract language. Allowable cost and contract structure are important. Medicare will treat certain portions of your provider compensation, ER availability, call, medical directorship, admin time as allowable costs on your Part A components. So you have to have that identified in writing. And then however you're tracking it, be sure it spells out in the agreement specifically what services, what's being covered, what's the FTE level, how many hours, what's that expectation, how much. Develop that within that agreement so that you can actually capture that in terms of that cost-based reimbursement. So with that, talk to your auditors if you have more questions directly. Best practices there. You will want to make sure that you can quantify that at the end of the day and looking at how is that tracked? Are there logs within what meetings they actually went to? Because you don't want your auditors or cost report preparers saying that you can't actually claim that. So be looking at how best to capture that. I felt that was probably the right place to say that, especially for the very first one we're going to talk about in terms of that model, and that's medical directorship. Many of you are going like, well, yeah, duh, we've done this for decades. You've had medical directors within your organization for administrative oversight or clinical leadership, development of your quality programs, specifically within like your surgery, ICU, ER development, etc. But it's really those things that go beyond that patient care. Why I bring it up and why I think it's important to continue to understand is oftentimes when you're looking at some type of employment model, whether it be a professional services agreement or truly an employee contract, you will have a subsection likely within that for medical directorship, whether that be for a clinic practice itself, some type of specialty services. For example, if you happen to have some type of employment for your CRNAs, you might have a medical director requirement within that so that they're providing that ongoing oversight and development of the administrative responsibilities, those policies and procedures. So you will build this into as subsets of the contractor. You might have a totally different agreement. So that's why it's critical to have, these types of components within that and why it matters. So not only regulatory compliance, that expectation of physician leadership, how much the time are they going to give you? And so it's really important that you define those effectively. Clinical co-management agreements. This built into exactly what the name of it. This is management of. Typically, it's a special service line. You're going to develop a cardiology, non-invasive cardiology, or maybe oncology. And so you have a group out there. Sometimes this can be with a physician group. And it might even be one of your tertiary facilities or even one of your competitors down the road that you want to collaborate with. Identify who's doing what and how do they get reimbursed for that. So that's why it's important. It increases that physician participation. It increases the alignment with your overall goals as a health institution, both for the hospital and the clinics themselves. Portions of what you want to include within that would include understanding how you're going to measure it, whether it be quality outcomes, operational efficiency development, patient and staff satisfaction, whatever it might be. Make sure you identify those up front and that you're actually sharing those ahead of time. Don't come behind it and say, did we achieve, when you don't know what you're trying to achieve. So develop those metrics in front. So how do those get actually compensated? I would tell you most frequently, my experience, these are fixed rate. They're a base management fee structure. But I don't want you to lose sight of the fact that they can be incentive compensation or at-risk models. Are we achieving the quality, especially if it's involvement of something you want to do within an ACO or some type of value-based services? Create the incentives within that. So there's some at risk. Maybe the base fee is only paid at 80% and you hold 20% back for meeting the operational efficiencies that you developed in your budget. The satisfaction of the services continues to be 5-star, or your quality continues to be high. Whatever those might be, you might put some of that fixed rate at risk. All right. Professional service agreements. So this is really your really entry into more alignment for practices. So what is a professional services agreement? It's a contract in which the hospital or health system actually engages independent physicians or a physician group. So basically, you hire that group. Why does that matter? Well, it supports clinical and financial integrations without requiring full employment. There's still a desire for some physicians to remain independent. They like that independent thinking. They want to be able to bring those skills to the table. It can also help stabilize community access. One of the examples that I'll share as I move forward was exactly that. Uh, a specialty group serviced the Quad Cities, in which the environment I was in. And as a result, one of the hospitals decided to go out and hire their own. And that really began to create some unrest for this practice. Well, the practice wanted to remain independent, but they needed alignment in order to allow that physician and hospital to share kind of that level of risk together. So that's a professional service agreement was perfect for that. Let them independent, but it created the alignment in the security moving forward. Within the professional services agreement, what's the purpose of that? Again, it's stabilizing that health environment. You want to retain good providers in your community. You don't want to sacrifice their independence. They want to maintain that, but it's really that first throw into an aligned, more employment type arrangement. The relationship, it's independent providers contracted for services. It really buys that seat at the table. Remember, I was talking to you about in the development of your strategy and learning about your processes. This was a great opportunity to get the physicians at the table to learn what was going on within the health environment. We think we know, but I will tell you, you often don't. There are times within your physician practices, especially in independent practices, they have worked real hard to refer within, but we put so many barriers up that we created such a challenge for them. They're left with going, well, I'll just refer to the competition down the road because they respond quicker, they get my patients in, and I get my results timely and accurately. And I will share, some horror stories within that as I progress through this. What are the key benefits? All right, well, let's look at it from the physician side. They maintain practice ownership, their own governments, they remain um, independent, and there's a lot of autonomy. It reduces their exposure. They don't have to worry about that administrative burden anymore. So no more collections or payer negotiations. That's all the hospital's problem, your problem now. They no longer own the new AR, so to speak. You as a hospital, you're providing that services now. You own it, and you're contracting with them to actually be the contracted employees to come in and provide that services. Why would you want to do this? Well, number one, it achieves reliable coverage. It creates stability within your health environment. It actually begins to align incentives across the players, and so that you can have good communication and conversation. And it doesn't force them into that one size fits all. It might eventually move towards employment, not necessarily, but it definitely provides deeper alignment. What PSAs are not, I will tell you, they are not flexible once you've created them. Doesn't mean you can't change them. They just can't be changed overnight and willy-nilly. They are written agreements. They take a long time. Most the PSAs I were involved with sometimes took over a year to create because a lot of discussion. There's still a lot of, do I really want to do this as an independent practice or do I not? What does it look like? So a lot of back and forth. Even in the best intentions and really both parties have decided this is the way we want to go, it can take nearly 6 months to create. There's a lot of documentations, a lot of investments, basically because you are taking over that practice. In some scenarios, when you look at a traditional PSAs, you're buying the assets, you're taking over the AR. Well, you're actually taking over the new AR. You might take over the old AR at a negotiated rate. You might even support the um, the actual collections of that AR, again, at some type of contractual rate for that practice, because they will no longer have billers employed through them, no matter if it's a global PSA or traditional PSA, because they become employees of the hospital. It's your AR, and that's really important. They're not inexpensive. They cost money to develop. That whole spectrum of alignment. So you got private practice, which is the maximum independence, moving to full integration, which is employment models. In between the two, you have a global PSA and a traditional PSA. Global PSAs are really continue to hold a lot of independence. They're not quite sure they want to be, employed, and we may not want to do this long term, so we may want to get divorced early, and much easier to do in a global PSA because they own rights, all the employee rights except for billing, where a traditional PSA really is a deeper strategic alignment. I'm going to share a little bit about what each is. That traditional PSA is you're employing the practice, the physicians only. All other employees are owned, managed, and ran by the hospital. The hospital just agrees to pay the physicians. In that contract model, it can be straight salary and it can be a base plus productivity arrangement. You're going to pay them whatever agreed upon time and rate. That means either biweekly to monthly to quarterly, whatever you agree upon. Whereas the global PSA is that practice remains largely intact. So all the nursing staff, front office staff, support, MAs, etc., remain part of that practice. They have to pay those employees. They have all the administrative burden to do so. The hospital pays that practice for that overhead and compensation, but that's developed through a budget and it doesn't change. So there needs to be communications. If the practice decides to add more staff, well, the hospital has to agree to that in long term. They can't just go do it, and that's the hospital's responsibility. You've agreed to the budget, it's set. You're going to have those discussions. That's part of that ongoing management of. Let me start with an example here, a case study. So we had one practice. I mentioned it early on. This was an independent specialty practice. They wanted to remain independent, but the economic conditions of the time really challenged them for that, especially in terms of recruitment, that long-term recruitment viability. They didn't see a pathway to it, which really put the health organization at whole at risk. Therefore, having a discussion of partnering made a lot of sense. So we entered into a global PSA within this environment. It has now been 4 years post that and has gone very well. Monthly meetings, discussions with the providers, a lot of clarity within how the practice is managed and how successful are they. I will tell you one of the advantages and oops. And I'm gonna ask my team. I hope I'm still live. I just got notice about a remote session being done, but I'm gonna keep going. So you want to make sure you have that alignment. Now, one of the things is they still own the assets, and you're going to lease those assets. What the complicating factors are is as time progresses, and let's say they need new computers, oftentimes the hospital is going to buy those and then just put them in. So you're going to have to review that fixed asset lease every single year. Do we still own this? Do they own this? Who owns what? Make sure that's clear, because if you ever do split out, you got to know who owned what. If you buy a new ultrasound machine for this practice, what does that look like and what does that mean? All right, now let's talk about employed provider. So that's really that W-2 employee. They are employed through you. You're going to provide them benefits. This is the full integration. This is our best opportunity for alignment overall. Many of you are familiar with that. You might have employed physicians, hospital services, or even your clinic staff could be definitely employed. Rural compensation reality. Oftentimes you're paying higher. So remember I talked about like that productivity, you might be working in the 25th percentile, but paying in the 50th or higher percentile. Why is that? Well, a lot of times you just don't have access to the volume needed to generate. On average, rural hospitals pay 50%, 56% of their compensation models are straight salary with no incentives. And this makes sense in some scenarios. I'm going to talk about what makes the most sense to where and why that might be. But that's just the true reality because it brings that stability and that security moving forward. Compensation rates oftentimes are a little higher on that work RVU value. If you're not sure what an RVU is, reach out to me. But CMS identified everything that providers do and gave them a weight, relative value unit. The W part of that is the physician component. Medicare pays on three parts, and that happens to be the provider side. So, what type of compensation models are out there? That's trying to make sure I stay on track with time. There are really multitude, any one of these, a combination thereof, a blending of, but they are straight salaries. That means a fixed annual amount. There are salary plus some type of quality incentive. There are base salaries plus some type of bonus structure. And then there's true, just straight, I hate to say this because I don't really like the term, but eat what you kill. What they are not. And I actually created this little slide through AI. I thought was pretty cool, but it's not the administration getting, into the Thunderdome of life and we're going to hash and battle this out. That's really not the right approach. You really want to have good discussion and what makes the most sense within what type of model do you want. So let's talk straight salary. Why would you do this? Well, there are sometimes very low, volatile segments of our population require it to be the right way to retain and recruit to your specific facility. They're very simple to administer. Your HR team knows exactly what they're going to pay, and your provider knows exactly what they're going to get. They're agnostic to any pair mix and any volume fluctuations. So if you might have seasonalities, this is one thing you might look at why to do it. One example of this that we created, we had a hospital, they wanted to develop a rural residency program in conjunction with a university medical school. Due to the nature of that ongoing precepting and educational part, straight salary made the most sense. However, in this environment, we left the flexibility open to create subset of that that might have some productivity. In that arena, that clinic needs to be thriving in order for that practice environment. That way, those residents get that full exposure to what a clinic is like. And so some of those physicians are truly half their time they're just seeing patients. Well, that might be an opportunity in which that physician might say, hey, I'd like to look at potentially a base plus model. But here in this scenario, it made the most sense out of the gate to just make it salary. So we did straight salary. Another scenario that didn't quite go as well, started out as a base plus, then turned to a straight salary model. This was really for the recruitment of more providers in order to offset the call burden. The challenge is once the providers got recruited, there was no alignment for future strategy. So providers went from working in the 75th percentile down to the 25th or lower in percentile, and we're getting paid at the median. Well, number one, it just wasn't financially sustainable for that health institution. And so they came back to the provider and said, we got to change this. Let's talk. Both parties really never had a clear identification, so that fractured the relationship. To this day, there's still a lot of distrust, even though it's moved back to a production-based model, but did not go well because really lack of alignment early on and definitely lack of communication. Salary plus quality incentives. This works really well for those areas that can't control volume. So you think about like your hospital services, maybe your some of your value-based modeling could be a component of quality. So if you need to see a certain amount of, you know, types of diabetic management, as an example, in an ACO model. How do you develop that quality incentive? I will tell you, if you're going to have quality as part of your contractual relationship with your providers, make sure it's clear, make sure it's measurable, make sure they're involved in the assessment of that, and don't make it too many. 3 to 4 probably is plenty. Um, if you make it too complex, everybody will see through the smoke screen of that and feel like it's just smoke and mirrors. They never intended to pay for it. So definitely think through that and how you would identify and quantify that. Then you have your base plus bonus. This is oftentimes what you'll see in many practices, especially primary care practices, not usually in your inpatient, your hospital is in ED, really can't control volumes, nor can produce inverse incentives like too many lab tests, too many imaging tests. But in primary care practices, oftentimes some base, how much am I going to make every month to pay my bills? And then if I do well, and I do a lot more than that, what do I get paid? Usually it's on a work RVU basis, $50 to $55, depending on the specialty. And again, you do external reviews of that. It really aligns incentives, it aligns throughput, it aligns a lot of that expectation, and it gives providers an opportunity to make more. This scenario here, I put a question mark on because it's really still out to vote, really early in diagnosis as in terms of success. I will say this was probably the highlight of my career. We had a practice that actually was struggling. That wasn't the highlight, but we sat down with them. We talked about a PSA model. They decided, no, we want to do an employment model. It took us, boy, almost a year in development, 7 months to be exact, but we needed to get them through that process. They wanted it to happen yesterday, and we had to make sure that everything was aligned. So we had a full-blown plan, all the way from the onboarding process to credentialing to marketing, and then, kind of that end phase. And everybody had a component and had to perform. We met monthly in the beginning, then it became twice a month, and then it became weekly as we got closer. But the providers and the administration met every single month, or actually every single week. Sometimes there were tears, sometimes there was anger, but we really hashed through it. The main thing was remaining consistent. At the end of the day, we got through it. And one of the providers, when this was approved by the board, came up to me at the end in tears, sharing that you remained true to your word throughout this whole process. They were skeptical in the beginning, but we just continue to make it very transparent, very clear, and at the end of the day, very rewarding as a result. I don't see a lot of pure, work RVU based pay. You're typically going to have these in really high volume, procedurally heavy driven environments, a specialist, cardiology, orthopedics, and you're already going to have the volume there within your market. I mean, most physicians are going to want some type of security, so it's usually going to be a base plus model, but there are truly an ability to have that. I just don't see a lot of them in a rural setting. What makes the most sense in matching that up to you? Well, first and foremost, I will leave you with this. New recruits, low volume, probably straight salary, with an opportunity to convert it to a more traditional base plus model as time settles out and to find out if we have the volume. If you have an established primary care, you already know what the volume is. You can set those base level salaries and then incentivize them from there. And then if you really try that high demand procedural, you could think about truly just a productivity. If you're having visitation or regional specialists come in, you're probably going to pay them a per day or per encounter. And so I would think through how to structure that appropriately. When you develop your contracts, make sure you document clearly. This is definitely the meat of what you want to think about in defining those contracts themselves, making sure you've gone out, is it fair market value, validated, And can we pay for this? Do I have within the agreement who's responsible for what? What are we responsible in terms of reporting? Do they understand if it's a production-based model, what the reports mean? Are you sitting down with them? How often do you sit down with them? Define all of that in your contract documentation. I think I've probably talked enough about that. We are running close to the end of time. Just some housekeeping items to think about, other considerations. So those hanging chads, build trust, be transparent, set your goal, write down your expectations, meet routinely. I don't know what routinely means to you. It could mean quarterly, monthly. You will have administrative meetings that have conversations. If they're employed, go to the physician's um, management meetings that they might have, an emergency group. They probably get together. As administrators, go there. If they're a PSA, establish your cadence of reporting and checking in, making sure everybody's on the same page, talking through the productivity, talking about the financial, where's the reality of the hospital. They want to know that. They're integrated. Remember, they're a part of your team now. Verify by building trust. Track performance, share with that, review ongoing, address issues promptly. What's the governance and decision-making process? Who gets to make the decisions? In a PSA, is it 50-50? Is it 51%, 49%? Who gets to make that decision? What's the voting requirements? Who's a part of those meetings and who gets to have a vote? Make sure that's clearly identified within the structure of those agreements. This is really out there, but in your contractual agreement, you might have some representation of call requirements. It might be like 1 in 4, 1 in 6 for primary care, especially like a pediatrician group. If it goes beyond that, what is the market benchmark for paying like 1 in 5 if they take on an extra day? Do they get compensated for that? How do you develop that within your structure? And then your recruitment and retention support. So that signing bonus, what are you paying for? That relocation? Are you going to have some retention component like student loan forgiveness? And what happens if they leave early? Do they owe that back and how much? You got to identify those things all clear. I have sat with physicians at the end of a contract that left early and it wasn't really clear who needed to do what. And then you're in this really gray, tough area. So the more you can have that built into your agreements up front, the better off you're going to be long term. Some compliance red flags, paying too much without justification. If you're going to pay more than fair market value, justify it, document it, know why. Verbal agreements aren't good. Don't have a handshake and walk away. Make sure you've actually documented and identified that. If you have an agreement, don't change it without adjusting it. I know of one provider did exactly that. They decided not to follow the agreement, and it made sense, but they didn't document why and got in trouble later because they didn't follow the agreement. Must-haves: have term, have compensation, have restrictions. All right. So the rest of this, I'm going to kind of go through this pretty quick. Within those provisions, have your termination clauses. Sometimes you want out of an agreement. You may want longer, you may want shorter. Typically, you see 60 to 90 days without cause. Of course, with cause is immediate, but without cause. What about any bonus repayments? What does that look like if somebody leaves early? What about coverage of tail coverage for insurances, etc.? If a provider wants to leave, what are the non-compete? Can you enforce it? Talk to your legal. What about non-solicitation clauses for patients and staff? Like maybe it's a year they can't take your patients nor your staff away from you. And what happens if they do? So work through all that. I just talked about malpractice coverage and that tail can get expensive. Know what your carrier requires. All right. I think I'll stop here with common mistakes to avoid. Don't think you're urban. Don't copy those. Don't make your deals informal. Make them formal. Don't overpromise, underpromise, and overperform is a rule of thumb. Your key takeaways are document, annual fair market value analysis, know where your contracts are, know where your gaps are. If you're not sure, get an outside group to come in and help you do that evaluation. If you want to look at your clinics as a whole, are they performing or not? Again, good opportunity to do a clinical evaluation on performance to be able to support the organization as a whole. Couple resources for you. We will make this slide deck available to you. And then finally, we are developing this 5 pillars of financial effectiveness. We will do insurance contracting